Hi, my name is Mike Jones. I'm the Medical Director for Training and Development at the Federation of Royal Colleges of Physicians. I and a few colleagues would like to share some work we've been doing using quality criteria to improve the working environment for UK core medical trainees. This work has been led by the JRCPTB, and it's fair to ask what that organisation is. The Joint Royal Colleges of Physicians Training Board acts to develop and oversee standard setting for the UK physician curricula. We develop these and then present them to the regulator, the General Medical Council. JRCPTB acts on behalf of the three UK Royal Colleges of Physicians, that is the College in London, the College in Edinburgh and the College in Glasgow. This presentation will be shared between myself, Dr. Miriam Armstrong, who's the Head of Research and Development at the JRCPTB, but also the co-chairs or chairs of the UK Colleges Trainee Committees. That is Dr. Amy Hulse from Glasgow, Dr. Gavin Langlands from Edinburgh, and Dr. Michael Fitzpatrick from London. So what are the quality criteria we're going to be talking about? These are a set of non-mandatory standards which have been developed by JRCPTB in association with a number of national partners, including the GMC, the BMA, the NHS across the four nations, and the training bodies who are responsible for implementing the curricula in each of the home nations. These quality criteria cover an entire curriculum, in this instance the core medical training curriculum, and are complementing the UK-wide postgraduate standards already set by the GMC. But why were they originally developed? Well, in 2013, a combined survey between JRCPTB and the London College found that some trainees were being put off pursuing a career in medical specialties due to the heavy service demands, which I think we're all aware of, but also paucity and loss of training opportunities and a very significant variability in the quality and availability of supervision. An effective response was required to keep the medical specialties an attractive option.
So in 2013, RCP London surveyed medical trainees about their experiences of training, and this identified three key areas for improvement. First, the considerable service demands compromise their ability to take up training opportunities, for instance, outpatient clinic attendance, teaching sessions, and courses. Second, supervision was variable, with some trainees struggling to get consultant feedback on their practice. And third, trainees felt unprepared to step up to the medical registrar role. These demanded an effective response.
So, what was the response? The response was to create an additional set of quality standards to enhance those already set by the regulator. They would cover the breadth of the curriculum and ensure trainees had the opportunities to develop the knowledge and skills they needed to progress. This slide outlines the process. It took around 18 months to create an agreed set of quality criteria from scratch. What do the quality criteria look like? We start with the overall program structure, then move into details of learning opportunities, supervision, and communication with trainees. Here are some examples.
I'm Amy, one of the IMT labs up in Aberdeen. One of the things that I found really, really useful was having my pre-op year appraisal, where in the north you have more than one program director looking at your portfolio, looking at strengths and weaknesses, areas that you need to improve on. It's really useful having more than one person's opinion and more than one person reflecting on your portfolio, and having different people discuss about how best to achieve things that you're missing, as well as commenting on strengths of your portfolio. So it's I found that incredibly useful.
Another of the 14 core quality criteria is the requirement for trainees to have their rotas published at least 6 weeks prior to post-commencement, with that rota covering around 4 months duration. And that's important for a number of reasons, not least because trainees are anxious starting a new post, so knowing what lies ahead in terms of the work schedule and on-call requirements is really helpful. Secondly, we all have exams and conferences and courses to plan as well. So that's another reason that getting the rota in advance is really important. And lastly, and arguably most importantly, we all have busy social lives outside of work, or at least we used to pre-COVID. But I'm sure, like myself, we're all really looking forward to meeting friends and family again in the not too distant future. And we need to be able to respond to that wedding invite in good time. We need to be able to plan childcare in good time. We need to be able to plan and do a shift swap for that event we've booked a year ago in good time. And so that's why getting the rota 6 weeks in advance, at least for covering 4 months, is one of the important quality criteria.
Another thing that I found quite incredibly useful was sitting down with my clinical supervisor and best, having a chat about how best to tackle the NRCP, looking at your certain blocks that you have within the year. Some blocks have more on-calls than others. So it was really useful to have a think about not just doing it and getting out of the way, but also when best to think about booking your MRCP, because the time that you're actually going to be able to study varies between blocks. So I found that incredibly useful to kind of sit down and think about the wider picture of not just let's just get it out of the way, but actually let's pass. So that was really, really useful.
An important part of delivery was to monitor whether the criteria were actually being implemented. The best way to do this was via the regulator's annual training survey, which has a very high response rate. Initially, there were very high improvements over a 2-year period, followed by a gradual levelling off. This was most obvious in 8 out of the core 13 criteria. This slide shows the overall pattern of results. More details are available on the JRCPTB website and in this journal article. But did trainees notice the difference?
Since the introduction of the quality criteria, 3 areas of improvement noted have been around the attendance at post-take ward rounds or handovers, outpatient learning opportunities, and bleep-free teaching and learning events. Attendance at post-take ward rounds at handover is important not just from a patient safety perspective, but also as an opportunity for learning, for feedback about your practice and personal development. Outpatient clinics are really the bread and butter of lots of specialty work in many fields, but these are challenging to attend for those junior trainees who have ward duties also. And finally, being able to step away from the ward without the haranguing of your bleep is so important to allow the trainee to make the most of their learning opportunities and teaching sessions. And it's fantastic to see that these metrics have improved over time with the implementation of the quality criteria.
It is gratifying to see that the introduction of quality criteria led to improvement across the domains. But of course, not all were equally easy to implement, and different approaches have been required. Cultural change to improve induction and the availability of bleep-free attendance at learning events. There has needed to be a review of behaviour, asking trainees to plan for examinations and other aspects of their careers so that they can progress in a timely manner. But also, it's been required that there needs to be augmentation of practical and operational procedures, including simulation training, to ensure that patient safety remains paramount. There has been an impact on training quality, and these quality criteria have demonstrated their value in raising the educational value and quality of training without the need for significant extra resource. When we're looking at the results, we need to find out why there has been such positivity. This has been associated with an increased awareness of what trainees want, including ensuring that there is additional support for assessment and supervision. The criteria has led to greater motivation by the training providers to attract and retain trainees, and this is facilitated by the generation of peer competition due to the widely available published findings from the NTS run by the GMC. Our next steps are, of course, to move on from CMT and generate quality criteria for the new internal medicine curriculum. The benefits from CMT are being transferred to the IM programme, which started in 2019, but I think everybody be aware that the COVID-19 pandemic has significantly impacted on internal medicine training, especially that associated with practical procedures and outpatient clinics. We're reviewing how the IM quality criteria can support the restoration of high quality training opportunities to again facilitate rapid progression for individual trainees through the training programme. So our take-home messages are that the quality criteria have proven to be an effective nationwide approach to training quality improvement, but it has required the relevant stakeholders to be engaged from the outset, that the trainees whom it will affect will also going to be involved right from the design of the initiative. Annual monitoring is critical to ensure that the standards are maintained, and the results being published undoubtedly maximise engagement. More information about this project and the data that's been accrued so far are available on these sites. Thank you for your attention.